And welcome back to Jeff Koinange Live here, Citizen Television. Dr. Githinji Gitahi, Group CEO, Amref Health Africa is in the house, and Dr. Loice Ombajo. She's an infectious disease expert at the University of Nairobi. Dr. Loice, real quick, I think it was the other day, the government of Kenya okayed a Pfizer vaccine for teens 15 years and above. True, false, good thing, bad thing? True,
and it's a good thing. I know there have been concerns and people are concerned, or is it safe for children? There's a wealth of knowledge now, and there have been a number of studies that have looked at children and vaccination, and they found that yes, it protects them from COVID. And I think what we've noted with the more recent variants is that we had a lot more children also getting infection as opposed to what we had earlier on. For children, particularly those who may have certain comorbidities, then it's important that we also protect them from COVID, because those ones can get severe disease. So it's been shown to work, and it's also been shown to be safe in children. And a lot of the side effects that people feared, oh, it will affect the heart, it will affect this, have not been shown to be any more common in those who receive vaccine versus those who did not receive vaccine. So it is safe, and particularly for children who may have comorbidities, then get them vaccinated. The government has now okayed it. Dr. Githinji will tell us about its rollout and some of the issues, and it's available.
Yeah. Has it been rolled out, Dr. G?
Yeah, from 23rd of November. They were allowed to, children between 15 and 18. WHO has okayed children up to 12 years and above. Kenya has picked, the Pharmacy and Poisons Board has picked 15 to 18. I think the challenge that we need to overcome is whether those children can consent to vaccination without the support of their parents or not. So there are those things, and I think the government is working closely with the counties to ensure that there is a mechanism for either verbal consent, texted consent, written consent, and those mechanisms will be there. But it's a good thing. Remember also that these children are also can be infected, will be infected, as Loice said. They can also spread to other people. And the thing that we want to achieve eventually is that you need to create a very hostile environment for the virus, generally. When you don't create a hostile environment for the virus, you allow it to replicate easily. And the more it replicates, the more likely it's going to make errors, and the more likely that you're going to get viruses that are mutated. So the vaccines provide a hostile environment that reduces the possibility of new mutations. Number two, remember that vaccination is not only personal level benefit, it's also a population level benefit. So when you get vaccinated, you're not only getting vaccinated yourself, you're also assisting us to achieve herd immunity so that we can reduce the infection of other people and over time manage the pandemic. So we must see it that way. It's not just selfishness, it's also about population level benefits as well. So it's a good thing.
Why 15?
I think the cutoff for the Pharmacy and Poisons Board was based on the data available. And they said, okay, the data available is good all the way, but I think we are more confident from here and above.
15. And to note that globally, our countries are also considering vaccinating up to the age of 5.
Yeah.
So with time, the data available for younger children will also be more robust. So this could very well, the age cutoff could very well come down with time.
Yeah. Are the parents bringing their teenage sons and daughters, are they coming, or are they afraid? Is there that vaccine, that fear?
So I think many hospitals that I know of sort of got the go-ahead and the circular from the Ministry of Health, I think just a couple of days ago. Yeah. So it's only as of yesterday that they started advertising that you can now bring your children. So I'm not quite sure what the uptake has been so far.
Are there plans to go to, let's say, high schools where kids are, or you need to go with their parents, or how's that going to work?
Those are the things I was talking about, that if you're going to go to a school and do wide-scale vaccination, and you're vaccinating people below 18, then you may need kind of a blanket consent from the parents, saying, if you have an objection, let us know. Instead of saying, give us approval, send an objection for your child. Then if you don't get an objection, then you assume consent. So those are things that we have to work school by school, county by county,
And the reason they picked 15 to 18 is because it's a large population. That's a population that, it's a significant number in this country or in
safety. It's safety.
It's about what what evidence was available for that age group.
It's safety. Yeah.
But you said WHO has approved up until from 12 onwards.
For Pfizer has been approved from 12 onwards. But the Pharmacy and Poisons Board Kenya here, based on the data available, felt more comfortable starting at 15 upwards. But also remember the other considerations, that if you look at the risk profile, it's also different by age. So vaccines are not only about, let's give them to people. There are two things. One is, how effective is it? At what age? At what dose? And where do you get the biggest benefit? That's always not put in place. You have to ask, where is it we are going to get the biggest benefit from vaccinating? Now, if the risk of children under 15 is lower and you don't have adequate vaccines, then you decide we are going to get the biggest benefit here, and therefore until we get more vaccines, then we come down to 12. For now, let's spare the available vaccines for this age group where we are going to get the biggest benefit. So there are a lot of multidimensional policy decisions, not just the safety and effectiveness.
Right. Yeah. Speaking of vaccines, do we have enough in the country of the Astra, of the J&J? Do we have enough, or is never enough?
For the number of people getting vaccinated, yes, we do. But having said that, I think it was around based, I think a lot of the calculation was based on the initial risk group or target population. But as we open up our target populations, we definitely need more vaccines coming in. Yeah. So at least for the target of end of December, there's enough until then.
Yes.
But then we'll definitely need more going forward.
There's enough for December, because now we are at 14 million. And I'm aware that there are many others lined up for delivery. We have a lot coming through in the next few weeks. So maybe we'll close the year with 20 million, who knows. So there is, as Loice is saying, there is the need to ramp up vaccination, because again, also the country has a capacity, and you can't hold too many vaccines because you're holding other childhood vaccines in the same stores. So you can't just keep piling them, because they're not kept in warehouses. They're kept in refrigerated places. So there is also the management of coming in and going out. So if we don't vaccinate fast enough, then the country can say, we have a batch coming, but hold it until we create space for it. There are also those challenges. But ideally for now, we have 14 million. They're enough for our target. But if you look at, the world is looking to vaccinate 70% of the country or any population by June next year. Now you have to start thinking about how many vaccines do you need now, between now and then, for you to vaccinate 70% of the population. You need 70 million doses for 35 million people, and we have 14 now. So between now and June, we must find another 60 million doses. Yeah.
And we still have to get in line in COVAX, or in line as a country, to wait our turn to get our vaccines?
There are many sources now. So, of course, COVAX is one, and COVAX is ramping up. Now, you see what happened, COVAX was held because the manufacturers were not supplying COVAX. They were first supplying their rich guys, the rich neighbors who bought at very high prices that are unknown. COVAX now is receiving, so COVAX is giving us doses. A lot of the ones coming now from COVAX. But then there is also the donations from friendly countries, and that's also ramping up, bilateral deals. And we still have 13 million, remember, we bought from J&J through Africa Union. Out of that, I don't think we've received more than 3 million, so we still have another 10 million that's going to come. So I don't think vaccines are going to be a problem at all. Now where we are, for Kenya, is not going to be a problem. The challenge is going to be overcoming the last mile access and ensuring that everyone has a vaccine near them. Then they can then decide whether to take it or not, but at least it's there.
And I hate comparing ourselves to other African countries, Doctor, but in your opinion, is Kenya doing well overall?
I think Kenya is doing very well. We have to give ourselves a pat on the back. Compared to many other countries, we have done way better. As you said in the beginning, just about 3.5% average vaccination rate in Africa, and we're above that. We're now approaching 10%, and in some places like Nairobi, as Dr. Githinji said, we're close to 30% fully vaccinated. So we're doing fairly well as compared to many of the neighboring countries. And I mean, our hearts have to go out to some of the neighboring countries. There's issues of security, of insecurity, there's issue of even just access and infrastructure. So hopefully these are things that can be resolved with time, because we can't be safe if our neighbor is not safe, If our neighbor is not vaccinating, then we're not safe either. So it has to be, hopefully this now reaches out to all the other countries as well.
Dr. G, is there that fear of dropping the ball, dropping our guard? And I know you've often mentioned the Swiss cheese approach, which I love, by the way. Is there a fear that, the mask will go away, you forget to sanitize, you forget to social, all those, that Swiss cheese? Is that fear?
Human behavior dictates that, yes, that fear is real, that people have become pandemic fatigued. We have seen people, even in Europe, you saw people on the streets. When the government put in limitations, said you have to wear a mask, people went on the streets with placards. So that fear is there. The question is, what do we do about it? I think it is time for us to continually work with the communities. We cannot go back where we were in March giving orders. We have to work with the communities. We have to make people understand why they are doing these things. We have to work with community health workers. We have to work with local leaders, religious leaders, continuously. And that should be for the long term. It can't be just, short-term thing. And that must include vaccination. The next thing is that we need to integrate this messaging into our lives. It can't be that there is a COVID message and then there is a health message. They need to be integrated. The same way we are saying now that COVID vaccines need to be integrated into the normal health service delivery. If you're going to the outpatient and you're going because you have a cough, or you're going because maybe you hurt your leg, the COVID vaccine should be available for you. You don't have to say, let me wait for the COVID day, or maybe go to the clinic that has. It should be integrated with routine immunization, routine service delivery, and the messaging should also be integrated with schools, for example. Schools are actually the best way to spread information to communities. We have used them, tested them for water and sanitation and hygiene. And when you teach a child water, sanitation and hygiene, how to boil water, how to wash their hands, that information without doubt ends up in the family and changes the family behavior. We should integrate COVID messaging into the school curriculum. Because if the children go back and ask their mother, why are you not vaccinated? Because they have been told by the teacher it's an important thing to do. So we need to move to the recovery phase and out of this response phase. Integrate this messaging into our schools, into general meetings, into the church, into the health facilities. Then we are going to achieve what we want.
Absolutely. Let's go to the magic wall, folks. This is great information. Let's see what the people out there are saying. Lots of tweets coming in thick and fast. Thick and fast. Up first, Lois Paul says, Jeff, a question to the panel. People say once you get COVID, you are as good as vaccinated. And rate of reinfection is very low, and therefore no need to be vaccinated. What is your take, Dr. Lois?
So when someone gets COVID, there's an immune response that's elicited, and that's what helps you control the COVID as well. Some of these immune responses tend to decay or go down over time, which means the COVID vaccine then acts as a boost to that immune system. So ideally, even after COVID, we encourage everyone to get vaccinated because that immunity dwindles over time. So yes, get vaccinated after COVID.
I've read of people who get COVID after the first jab. Have you heard of that?
Yeah. It's possible. And you can get COVID, then get jabbed because you didn't know you had COVID, and then you have COVID. You can get COVID after the jab. So it's a spectrum. But we know that even when you're fully vaccinated, you can still test positive for COVID. And we said that before, that what you should worry about is that even if you're vaccinated and you get infected, the rate of replication of the virus, because of the hostile environment in your body that has been created by the vaccine, the virus will not replicate enough to give you actual disease. So being positive of a vaccination is not a surprise at all. What is surprising is when you have what we call a breakthrough infection or breakthrough the disease, where you're vaccinated, you get COVID, and then you go down to severe disease. Those are the ones Loice was talking. That happens in a few people. It's very few people. That's where the surprise is, and that needs to be studied more. Where do you have breakthrough infections? There are a few studies. Right. So getting vaccinated and being positive should be no one's surprise.
Gotcha. Thank you. Janet Kimutai says, with the virus mutating day in, day out, will this mean that we'll have to get vaccinated for every new strain of the virus? Dr. Lois?
So two things here. One, that sometimes the immune response that you get from the vaccine is able to overcome several variants. So, for example, there was a Delta variant, and we knew that many of the people who had already been vaccinated were still protected against the Delta variant. So when a new strain comes in, the studies that are done is to look at some of the immune responses that someone has elicited and see if that is able to neutralize this new variant. Okay? So occasionally find that, yes, it's able to neutralize. At some point, you may find that there's a new variant that cannot be neutralized. We don't know the answer to that yet for the Omicron variant. I guess the other thing to say is that the more people are vaccinated, the less variants will have arising over time, because there'll be less virus going around anyway. So let's get everybody vaccinated so that we have fewer opportunities for this virus to multiply and change itself to give us the variants.
Yeah. Okay. Cecilia Mutemi, Jeff, ask your two doctores their position of the vaccines on BP patients, deep vein thrombosis and renal patients. Doc?
There is actually, you see the people we're calling the BP patients, that's blood pressure patients,
Right.
are one of the groups that we consider high-risk groups either to get COVID infection. Those high blood pressure patients, people with diabetes, people with cancer, and other conditions that we call comorbid conditions, are the first ones in the queue to get vaccinated. Because if they get COVID, they are more likely than the average person to get down with severe disease, be hospitalized, and probably death. So there is no fear to vaccinate people with blood pressure. There's no fear to vaccinate people with renal disease, and we should. In fact, people with diabetes will often have renal disease if the diabetes has not been well controlled. And they are also first in the queue for vaccination. And this question keeps coming up all the time. I hear people saying we didn't vaccinate our parent because they have high blood pressure.
Right.
And 1 or 2 times I've had the same people call me and say, oops, our mother died because we didn't vaccinate her because we feared the hypertension. So the COVID killed them. So let's get our patients with chronic disease vaccinated without any ounce of fear. Yes.
Good point. Good point. Moses Kimngatich says, Jeff, kindly ask Dr. Githinji and Dr. Ombajo if the symptoms of the new Omicron variant are similar with the past COVID-19 variants. Is it too early? Is it? I mean, we hear they're mild so far, but
So far, the information we have, at least from colleagues who've managed patients who have this Omicron variant, are that the symptoms are fairly similar to what we've seen with the past. As I said, we still do not have any data. They haven't seen too many patients who got severe disease. So far, most of the patients they've managed have had mild disease. But as we said, it's still early days. So as time goes on, we'll have a little more data on that.
Yeah. Let me explain something, Jeff, so that we kind of, people understand this variant thing. Because people find like a variant is maybe you had a type of a car and now it's a totally different type of car. No, they're exactly the same. What happens is this. So you have the virus, and then the virus has a certain shape. That shape is what has the spikes, that crown that makes it, let's call it corona. Now, that corona is the crown. Now, those spikes are the ones that help it to attach to your cell and infect the cell. Inside those spikes, in the ball, is the DNA or the RNA that actually then decodes and tells the virus how to behave. It's the genetic code. Now, this spike is purely for transport. It is the one that helps it to attach. Now, the variants that we know so far happen on that spike. So this particular variant, Omicron, has a lot of changes, mutations. And the mutations means that if you had the gene code organized as A, B, C, D, E, F, G, then you maybe have the D deleted, it disappeared, so you have A, B, C, E, the D disappeared, or maybe you have the E coming before the A, is rearrangements or deletions. So it's the same thing, but those deletions or rearrangements then may create a change on the spike protein. It doesn't delete it, the spike protein is still there. But if the shape was this, maybe the shape now becomes that. The shape just changes a little. That's why the vaccines, because they were created for this spike protein, still work. The change is not major to stop the vaccines. Now, when we talk about variants of concern, it means that maybe the change on this shape was so significant that it changes the way the cell attaches, the virus attaches to your cell. Maybe then it makes it more infectious. That's what happened to Delta.
Right.
Or maybe it makes it cause more severe disease. Or maybe it makes it changes shape that it escapes the antibodies that were created by the so it's not a totally different virus. It's just the same virus with a few changes. The way I can now go and remove this lapel or remove this hanky. I'm still the same person, but I look different and maybe I behave a little different. But it's the same virus. Yeah. So let's not people fear that maybe this is a new animal, that we had a hare, now we have a lion. No. So people need to remember it's the same virus, just with small minor changes that make it behave differently.
And that's why Delta was so deadly?
Yes, Delta was a variant of concern because it was more easily transmissible, which means where in the past one person would infect 2, now one person was infecting 7, for example. It was more transmissible. So when we say a variant is of concern, it's either you can transmit it, it's more transmissible, it will spread faster in the community, or it will cause more severe disease when it infects people, or it may escape from vaccine control, so to speak. So with Delta, it was because of how fast it could be transmitted or how much more it could be transmitted.
Gotcha. Nyamogo Gogni says, kindly ask our guest doctors that of the vaccines we have in Kenya, from Moderna to AstraZeneca, Pfizer, and J&J, which one is safer for 65-year-old with a NCD like arthritis?
The only vaccine that's not safe is the one you don't have.
Nice.
So all these vaccines are safe. And we must avoid saying, I want this one because I have this and I want this. They are all safe. And there are no safety concerns that have been raised for any of these vaccines for somebody with any of those conditions.
Yeah.
Yes.
The best vaccine is the one closest to you.
Or the one inside you.
Or the one, the best one is the one inside you.
In your arm.
The second best one is the one that you can get today.
Exactly.
Yes. Very good. Very good advice. Nay, Anthony, please enlighten us about vaccines and pregnancy. Are vaccines safe for pregnant women, Dr. Loice?
Yes. And one of the things we've noted, especially with the last wave of COVID that we had pregnant women come in with severe disease. We lost a lot of pregnant women. Many of them had not taken up the vaccine in March because they were pregnant at the time, but we ended up with a lot of mortality in pregnant women. Pregnant women should get the vaccine. It's not too late. Early pregnancy, late pregnancy, when they can, let them get that vaccine.
Dr. G, you're nodding.
100%. And I was always of this position from the beginning. We talked about it differently. And I think there was different flow of information. That's what created the hesitancy. Initially, no, don't get vaccinated. Get vaccinated. When you're pregnant, planning to get pregnant, when you're breastfeeding, get vaccinated.
Very good. Joel, Jeff asked the doctors, what are some of the long-term effects after exposure of COVID? Are these effects reversible? We talked about everything from smell to taste to things like that. Are they reversible?
So, we talked about this earlier. Some of the long-term effects that we have seen, one, fatigue seems to be the most common one. We have people who have these joint pains and muscle pains or some headaches, and then some may have this loss of smell or taste. And the lung, for those who have very severe disease, may take a bit of time to recover. So with time, most of this actually resolve. So it's really an issue of maintaining a healthy lifestyle, preventing reinfection, getting vaccinated, and giving it a bit of time.
Agree?
Agree, 100%.
The Patriot says, can one receive a second dose 7 months after receiving the first? Why 7 months? I'm sure this person forgot. This is Henry over there. He's 7 months.
Wow.
Again, he said it's okay. I mean, right?
First, I want to understand.
By 7 months.
I got my vaccine in April.
Yes.
Okay?
Yes.
So did this person also get it in April? And it's not like we've had these vaccines for 2 years. Like, where were you? But let's put it this way, that scientifically we know that you get the first dose. Science has given us the data that you wait a certain point so that you give now the secondary response to your body so that you get the best effect. For AstraZeneca, we've been told 12 weeks, that's 3 months. There's some data that says maybe even 4 months might be better, as Loice was saying, okay? Maybe for Pfizer, Moderna, you're told 4 weeks, okay? These are not absolutes.
Right.
They are when you get the best response. Even when you say vaccines, like when we talk about malaria vaccine, we say it's most effective in this age group. But it doesn't mean it's not effective in other age groups. It just means that it's less effective. So there'll be no harm. But I would advise that if you got 7 months ago. You get another dose now. We know now that people are saying probably the immunity may wane at 6 months, 7 months. So I would say it's wasteful, but I would say maybe Loice has a different opinion, and that's why we're here, two of us. But I would say if you're going to get another dose now, wait for 12 weeks and get another one, because then you just take another kind of regime.
Right.
Yes. Or get J&J and get single dose or whatever. But 7 months, I don't think I have any sign that says that second dose is
This is one of those where we don't have answers.
Yeah.
So they're an outlier. We need to study them and see what happens.
Yeah.
So we don't really have a clear answer as to whether you should just get a booster, whether you should just get a second dose, or whether you need to restart that whole regimen.
Right.
As I said, it then becomes wasteful, because then you're spending 3 vaccines on you when someone else hasn't gotten a vaccine.
Yeah.
So people should try and get a message from Chanjo telling you go for your vaccine. And
where's the patriot been?
The patriot.
Yeah. For both of you, does it get frustrating sometimes with such a new virus, with so many unknowns? Does it get frustrating sometimes, Dr. Loice? Because you think you know this. Because in the beginning, we used to argue, you can't mix and match doses. Remember we said that? It's okay. Does it get frustrating sometimes? You can't nail this thing down yet.
So there are 2 frustrations for me right now. One is that over the last couple of months, we've had a lull, and we're really hoping that, we'd sort of gotten over this, and this was it. And now this comes, and we're thinking, no, we are tired. We don't want to have to deal with COVID again. So it's the hoping that this turns out to be fairly mild and will not really turn out to be a variant of real concern, so to speak. So that's one. The knowledge is quickly evolving, and I think one of the things that COVID has taught us is a lot of humility. You never know everything. What you know today could change tomorrow. I could come here saying something, and he says, no, there's this data that has come out today, and you're the one who hasn't seen it. So there's a lot of humility that has come with saying, we don't know everything. We're still learning, and we are using the best evidence that we have, the best experience that we've gotten to make good decisions. So it really has been a steep learning curve, and clearly we've not passed this school, because we still have to take the classes over and over again. So there's still going to be a lot of learning going forward.
Yeah. Dr. G?
Well, I think my biggest frustration is I feel like I'm running a race against WhatsApp. Like, you always have to be ahead of WhatsApp. Because you say we have this conversation, tomorrow somebody will circulate a video on WhatsApp that is saying something different. And now we have to, I feel like this race is like a marathon that's not ending. People need to seek information from reliable sources.
And Dr. Githinji, why is it that false information gains traction so fast? Why do people believe the wrong thing?
It is the same old story that if in a village a man bites a dog, the whole village will know. It'll be Jeff who beat a dog. But if a dog bites Githinji, it will be like, Githinji was made by a dog. That's it. No. So this is the problem. So false information or different, it gains more traction. And this race against WhatsApp is tiring, it's exhausting. If people can just say, let us seek information from the right sources. If you get information, just go and Google a WHO site, or Google an Amref Health Africa site, or Google a particular site. And if you get somebody giving you information, this is something else I do. Because people quote, doctor, professor, this and this said. Go and Google that name and ask. You find the CV of that person. That person will have been expelled from a university. That person will have been maybe in a government job and they were fired because of anti-vaccination. If you just do a bit of digging, the information is right there for you. Yeah. So please save us this run against WhatsApp. Let's just take information and trust it. We are not lying to you.
Yeah.
We wouldn't come here to lie to you.
You don't need to.
We don't need to.
Yeah, you don't gain from it.
Yeah.
But you're right. Bad news spreads so fast.
Yeah.
People love a bad news story. You tell them some good news, who cares?
Exactly. When do you use that thing, Jeff, that red thing next to you? When do you use it?
You are not controversial enough. If you were an anti-vaxxer, we would...
There's a question here, okay?
Yes.
And I'm reading it cold. I'm just looking at it right now. A lady got COVID while 28 weeks pregnant, okay? A baby was evacuated. I guess the baby was... and both taken to ICU. The lady tested negative in 2 weeks, but as she was getting ready for discharge, suffered 2 heart attacks. She's been in hospital since, and it's been 4 months, 54 days in ICU, 35 days in HDU, 36 days in general ward. She still needs oxygen from time to time. Why?
So the reason why we should vaccinate pregnant women, but then we know that with COVID, there's an increased tendency to clot. Yeah. And these clots are often in the veins, but we've also seen clots that happen in the arteries, and that's why people get a stroke or a heart attack. So that's not surprising. Strokes and heart attacks have happened in the context of COVID because it increases the clotting in the body. So in such a situation, it's unfortunate, and our heart goes out to her and hope for very quick recovery, but those things do happen. And that's the reason why people should get vaccinated, so that we do not run the risk of such eventualities.
Exactly.
Absolutely. Dr. G, anything to add?
Nothing, absolutely. I think we just need to remind people that vaccination is the right thing to do. Vaccines are safe, they're effective, and all those rumors you hear, if you are afraid of the needle, it's painless. Let's just tell them that. A lot of people, a lot of people, I didn't feel pain.
Unless you feel pain?
Saying nothing.
A lot of people are afraid of the needle, but they're using all these videos to confirm, to say, oh, I don't need to get vaccinated. Because, deep down, it's phobia. Deep down is phobia. It's a fear. So let's support our colleagues to get vaccinated and overcome the fear.
Including professionals and doctors and experts.
And I guess the other thing to add is the vaccine does not take away from the need to observe the other measures that we've been observing for the last 1.5 years. So for now, we still need to wear our masks. For now, we still need to think about avoiding these gatherings in closed spaces. We still need to maintain hand hygiene and do all those things that we've been doing for the last 1 year. Even with the vaccine, it will take a while before everybody is vaccinated. New variants are coming up that we do not totally know about. So let's continue to keep safe.
Absolutely. Dr. Loice Ombajo, Dr. Githinji Gitahi, both great to see you as always.
Thank you.
All right? Next time I'll show you how this thing works, okay?
Okay. I'll come ready.
Great conversation as always. And thanks so much for being a part of this great conversation, folks. Any questions, comments? You saw the experts. You heard from the experts themselves. There's nothing to fear but fear itself, folks. And there are going to be more variants, but the more of us who gets vaccinated, the better it'll be for all of us. We're all in this together. And that thing about public rallies and those things, that's going to work, huh? You get your jab, and then you go and,
And go to the rally.
Yeah, go
Exactly.
rally.
Yeah.
I mean,
fantastic.
The Minister of Health recently said, let us, the politicians, encourage people to get vaccinated. So this is a good idea. We push people for vaccination.
Yes. And then
at the same time,